And to start our afternoon session, we are privileged to hear from Professor Jau-Ching, Director of Neurohelatabilitation at TVGH. Professor Wu will present on the crucial topic of surgical treatment for brain tumor. So please give a warm welcome to Professor Wu.
Thank you, ladies and gentlemen. Today, I'm going to talk about surgical strategies for brain tumors. Can I have my first slide?
Oh, so you want to go to the next slide? 下一张吗?
Yeah, okay. Yes. So when we talk about surgical approaches for brain tumors, this is the most fundamental but also the most critical strategies in neurosurgery. There's no brain tumor that is identical among each patient. So we would like to divide brain tumors into extra versus intra-axial ones. That means some brain tumors are arising from outside the cerebrum or the cerebral cells, astrocytes. Some tumors are intrinsic. That means it's derived from the brain tissue itself. For example, extra-axial brain tumors refers to those arise from the meninges or skull bones or even cranial nerves. For example, there's meningioma, carcinoma, pituitary adenomas. And on the other hand, for intra-axial brain tumors, that means astrocytomas, which is gliomas, or medulloblastomas, or even metastases. These are the intra-axial tumors. Most neurosurgeons would like to deal with extra-axial brain tumors because those patients tend to have better outcomes because it's not the brain tissue was affected itself. It's something from outside. The brain tissue is compressed. If we take it out, then the patient will be better, will be fine. For example, these meningiomas can arise from either the dura or even like the fox. This is called a fox meningioma. The one that is next to the parasagittal sinus is called parasagittal meningiomas. And there are all these locations, brain tumors of meningiomas of different locations that arise from the skull base. For example, this CP angle meningiomas. On the other hand, in contrast, for the intrinsic brain tumors, if you want to take out a glioma that is here, then you have to cut through the cerebrum and go into the brain. So these are intrinsic brain tumors, intra-axial tumors. This takes a specialized approach. For example, going down from this sulcus or transcallosal, transventricular, all kinds of approaches. So I would like to talk about the 5 most classic and fundamental surgical approach. 5 different types of craniotomies: Tyriano, interhemispheric, suboccipital, transsphenoidal, and far lateral approach. By these 5 approaches, we can take care of at least 95% of all the brain tumors. And these approaches, each of them can meant for example, like this Tyriano goes to frontal temporal lobes, and the interhemispheric goes for most supratentorial brain tumors, and suboccipital goes to those cerebellar tumors or infratentorial tumors, and transsphenoidal goes to those tumors at stellar region or clival region, for example, pituitary gland tumors. And far lateral approach goes to brainstem and those located at brainstem or cervical medullary junction. And we take this, for example, for the Tyriano approach. by going anterior lateral oblique, this trajectory, it can take care of most brain tumors in the frontal lobe, temporal lobe, and a lot of stuff at the mid portion of the cranial fossa. Something at the brainstem or midbrain can be taken care of by this Tirano approach. And this Tirano approach takes out this part of the bone, the frontal bone and most of the temporal bone, and get this lateral axis angle. By taking out this piece of bone, it takes care into the frontal, temporal, and a lot of lateral fissure, goes down to the deepest part at the center of the cranial fossa. So Tirano approach alone itself can take care of like 2/3 of the supratentorial brain tumors. And it can, by drilling off these scar-based bones, these tumors can be approached, even those around the optic nerve. And there's a modified version of Tirano approach that takes more piece of bone at the lateral border of the orbital wall and take out the zygomatic arch. By taking out this piece of bone, we further get the access or the upright angle to the brainstem. So this orbital zygomatic craniotomy is a modified approach for Tirano, and it takes care of all the brainstem pathologies. For example, even a basilar tip aneurysm can be approached. And the second approach I want to talk about is interhemispheric approach. By definition, you can imagine it's something that this approach goes from the two hemispheres in between. By splitting the two hemispheres, we can take care of pathologies in the midline. And traditionally or conventionally, we place the patient supine and take this sagittal sinus vertically. Then by splitting the cerebrum from the midline, that goes down into the deepest part at the midline. We usually, or previously, 20 years ago, we do this vertically. And nowadays, we tend to place these patients more horizontally, because by placing the patient horizontally, we have this gravity retraction that the lower part of the cerebrum will fall down spontaneously and get the excess of this angle. Then that spares the need of using retractors, which will have less retraction on the brain tissue, and theoretically protects the brain better. For example, by going the ipsilateral interhemisphere, you can take lesions here. We can also go contralateral interhemisphere to go to the lesions on the other side by gravity retraction of the ipsilateral cerebrum. You can see by this placing the patient horizontally, you can see this cerebrum falls down nicely after drainage in the CSF. Then we can get this access even deep down to 5-6 centimeters. These vascular lesions or brain tumors can be taken out through this interhemispheric approach. Here are some case examples of us. This is a 20-something-year-old male who presented with seizure during his school in high school, and we found this brain tumor here. After a couple of years, the tumor has gained size, so we did this approach to take it out and followed up. He has been great till now and become seizure-free afterwards. That's another example of a boy who presented with headache and vomiting. And there's a brain tumor here in the diencephalon, which means in the midbrain. And of course, there's also obstructive hydrocephalus. So this patient, due to the severe symptoms, we got the shunt first to take care of the hydrocephalus. after the drainage of the CSF, we get more space or access to the brain tumor. And then we took the tumor out and followed up. She has been quite good. The tumor has gone since then. Here is a third example. This is a case we did a few months ago. This is a female patient who is 29 years old. She presented with only slight headache, and she incidentally found a brain tumor in frontal lobe because of a minor head injury. And we did this in our hospital, that we have a intraoperative MRI. That means we perform the craniotomy, and before putting back the skull bone flap, we take the patient for MR exam to make sure the tumor, we get adequately the entire tumor. This is the patient before closing or putting back the bone flap, we send the patient to our intraoperative MRI. And during the surgery, we use the navigation to locate the small tumor. And this tumor is likely a low-grade glioma. So during the intraoperative MRI, we found there's likely something left here. So we take the patient back to the OR and take further out the smaller piece residual using the intraoperative MRI and neural navigation. That is the latest technology we have in our hospital. So by doing so, we make sure that all, or even 99 or maybe more than 100% of the tumor is taken out. Because since the pathology confirmed it's a low-grade glioma, I think this is the best management for this patient. The third approach I want to talk about is a suboccipital approach. Suboccipital means that we go to the infratentorial portion, that is the cerebellum. And from going this, we're going from the back to the midline portion of the cerebellum. That goes directly to the brainstem and tonsils, and here's the spinal cord. And this is most often used for pediatric brain tumor patients. For example, medulloblastoma. Medulloblastoma is the most common malignant brain tumor in children. Here's you can see the incidence rate until age around 10. So before teenagers, this is the most common pediatric brain cancer. Then in contrast, adults, glioblastoma multiforme is the most common adult malignant brain tumor. And the typical presentation is that it is a posterior fossa tumor that is presented with obstructive hydrocephalus and some cranial nerve deficit. The patient might be presented with ataxia and the focal limb incoordination. And recently, there's this molecular subgrouping to further divide these patients into 4 subgroups. The first one is Wing pathway. This Wing subgroup has the best prognosis of all 4 subtypes of medulloblastoma. And these children tend to have more than 95% of 5-year survival rate. And there's rare metastasis at the time of diagnosis. And if there's relapse, usually it's in lateral ventricles. The second subgroup will be Sonia hedgehog. This is the most common medulloblastoma subtype, and usually presents with kids under 5 years old and has a overall survival rate of 80%. And there are often T53 gene mutant in this subgroup, and the relapse usually comes at surgical tumor bed. And group 3 is very aggressive. And this one has probably has the worst prognosis among these medulloblastomas. And when it relapses, there often comes with leptomeninges seeding. And group 4 is something we know that it is the least understood subtype. And it has an intermediate subtype with transition features that has a better prognosis. And when it comes to treatment strategy, we tend to classify them into low risk, standard risk, high risk, and very high risk. You can see the survival rate has very significant differences. And usually, when it comes to management of medulloblastoma, we do maximal safe resection. Maximal safe resection means we aimed for gross total resection of the tumor or near total resection of the tumor. And then by classifying those tumors into risk groups, then it comes for radiosurgery or subsequent adjuvant surgery, adjuvant therapies. And first of all, we usually have to take care of obstructive hydrocephalus if there's a CSF circulation problems. And the longer anesthesia duration, that means if you take a long time during surgery, then usually there's some significant neurocognitive decline after surgery. And children, except for infants, may need radiotherapy for these patients. Typically, those with metastasis that needs radiosurgery through the cranial spinal axis, that means radiotherapy for the brain and spinal cord also. And chemotherapy for those high-risk groups, typically we use vinblastine and other kinds of chemotherapy agents. And of course, there are side effects of radiotherapy in patients that are very young. So we tend to save the radiotherapy later if possible. And here are some case illustrations. This is an 8-year-old boy who presented with dizziness and nausea. And you can see a large tumor here with dilated ventricles. So it's a typical medulloblastoma in the posterior fossa that causes obstructive hydrocephalus. And we did an endoscopic third ventriculostomy, and followed by a VP shunt. Then, in addition to the suboccipital craniotomy I first mentioned, after taking out the tumor, you can see this is gross total removal of the tumor, and post-op there's no spinal seeding. So, and the patient was medulloblastoma, and it's a non-winged, non-Sonia hedgehog. So we did a radiotherapy for this patient, tumor bed at 5,400, and with the seeding at T45, so another 4,500 radiation. And also, because of metastasis and the relatively high risk group, also the patient needed chemotherapy. And that's a post-op 6 months. And post-op 1 year and 2 years, and the patient did fine. This is another case example of a very young girl who is only 1 year, not even 2 years old, and she presented with unsteady gait and frequent falls for 2 weeks. And there's this large tumor here, and again with obstructive hydrocephalus. So we did a suboccipital craniotomy, going from the posterior. Again, after surgery, the tumor is completely gone. And it's a desmoplastic nodular type. It's a Sonia hedgehog activated and P53 negative, which means she's of relatively low risk. And here's the follow-up at 3 months, 6 months. Now she is, I think, 3 year post-op. She is quite fine. And here's another example of approach for the posterior fossa. It's called retrosigmoid suboccipital approach. In contrast to that midline posterior approach that is slightly lateral and takes care of the cranial nerves at the cerebellar pointing angle, typically for this acoustic neuroma. For example, here's a brain tumor at a meningioma at the cerebellar pointing angle. And after this suboccipital retrosigmoid craniotomy, the tumor was grossly, totally removed. And then the fourth approach I'm going to talk about is called far lateral approach. It is an approach towards the posterior fossa and the upper cervical spine that aims at the cranial-vertebral junction, cranial-cervical junction. By taking out the piece of bone, we can open up the foramen magnum. You can see the cerebellum here, brainstem here, spinal cord, and the vertebral artery, and all the cranial nerve 9, 10, 11, and 12. And this approach takes to all the brainstem and the upper part of the cervical spinal cord. Here's an example of this foramen magnum tumor that has completely blocked the cerebral medullary junction. And you can see here the tumor is here, and the spinal cord is here, and the brainstem is compressed towards the posterior end. And let's see if my video worked. Can you play my video? This is a surgical. Oh yes, thank you. This is a surgical video that by drilling out the condyle, that means taking out this part of the bone, and we already take out this piece of the skull bone that exposed this cerebellar, and here is the cervical medullary junction. And now we cut the dura, we tuck the dura mater, and now down here exposed is the cerebellar here, and the foramen magnum here, and down to the cervical spinal cord. And here is the tumor, and all these very tiny lines are the cranial nerves. And we try to coagulate them, and then we can take this brain tumor, meningioma, piece by piece. And here is the brainstem. And by this surgical approach, we did not have any retractors, or we didn't have to retract or move the brainstem. We didn't even have to touch the brainstem to any extent. And using this ultrasonic aspirator, we took out the brain tumor fine. And that's the pre-op, the brain tumor here, the meningioma here, and after surgery, the brain tumor is completely removed, and the patient recovered very well. So here comes to the last approach I'm going to talk about. The last approach is for pituitary macroadenoma. For example, this is a normal pituitary gland. Normal sella is less than 1 centimeter. Then here it's a large thing. It's called pituitary macroadenoma. And when it comes to this tumor near the center of the brain or near the center of the head, usually you can go this way, right? That's what neurosurgeons do 30, 40 years ago. Then since the 1990s, we have been started doing this transsphenoidal surgery. That means by penetrating this sphenoidal sinus, one of the paranasal sinuses, it's easier to go in to take out this pituitary macroadenoma without violating any of the cerebral tissue. And again, going here apparently spares the brain injury and has a lower chance of the other complications of the brain. And it used to be, when I'm a resident, we used to do this through this, it's called sublabial approach. that going into the sphenoid sinus by cutting the nasal bones here, going like this. And then in the past 20 years, our hospital has, we pioneered the endoscopic transnasal surgery in Taiwan. So by using the endoscope approach, can going down to the sphenoid sinus and to directly approach the sella, which is right in the center of the brain. Here's a paper that we probably should, in our team, to look at the giant pituitary adenoma. Any pituitary macroadenoma that is more than 3.5 centimeters at any of the axes would refer to a giant pituitary adenoma. You can see after this endoscopy approach, you will only have this tiny piece left, and the entire tumor is gone. This is another example case, pre-op. After surgery, the tumor is entirely removed. You can see average pre-op tumor size was 29.7 cc, and post-op is only 3.2 milliliters. So in length of follow-up, so more than 5 years. Here's the other paper that we use the same transsphenoidal endoscopic approach to treat Cushing disease. Cushing disease, that these patients have excessive ACTH secreting. This excessive ACTH secreting will cause Cushing disease. And this hormonal disturbance is very difficult to manage. Usually, we want to take out the entire pituitary adenoma out so that the hormone can be better controlled. So it's pre-op, after surgery. You can see anything in the midline is easy for transsphenoidal surgery. And what will be problematic is something lateral, particularly that close to the internal carotid artery. That would have some risk. And by using this endoscopy approach, you can see after 2009, we have better Cushing disease-free survival after this endoscopic surgery. And we also published this paper to look at those patients with pituitary adenoma and acromegaly. Acromegaly is these patients typically have excessive growth hormone secreted in adulthood with concomitant elevation of insulin-like growth factor 1. And it is a rare endocrine disorder typically caused by a pituitary adenoma that frequently needs neurosurgical management. And the common presentation included enlarged hands, feet, forehead, jaw, and nose. Those patients with gigantism. There are also complications such as diabetes, sleep apnea, and high blood pressure, and it is reasonable to expect association of acromegaly with higher chances of cancer because of the excessive growth hormone secreted by the tumor. And there might be increased risk of a cardiovascular disease and higher rates of mortality. So there have been reports on this association with premature mortality from cardiopulmonary disorders and certain malignancies. Even the excessive growth hormone might cause malignancy. But that exact incidence and risk of cancer and rates of mortality remain elusive. So we did a study, and you can see there's excessive risk. It is a standardized mortality rate. It's twofold higher for those patients. After treatment, the standardized mortality rates will gradually decline to normal, which is as normal population. And there's slight difference between the genders. And here again, we further divided these patients into early onset, middle onset, and late onset. You can see the early onset patients has the worst outcome, that is, has the highest standardized mortality rates. That means these patients should be neurosurgically managed as early as possible. And the incidence rate of this acromegaly is actually it's not quite high. It's only 2.78 per million person years. And in this series, 56% of the patients had this hypophyseectomy, that is, had this pituitary surgery. And the median survival was only 4.6 years. And we also look at the cancer risk. This is a standardized incidence rate for cancers. You can see all the cancer rates have gone higher. And the early and middle onset patients had a higher risk than the late onset patients. And there were 87 newly diagnosed cancers in this cohort. And the overall standardized incidence rate for cancers was higher. And there were no differences among gender, onset age, and disease duration. So we concluded that, in that paper, we concluded that acromegaly is associated with an excessive risk of mortality and twofold higher risk of cancers. So patients with acromegaly should be managed appropriately after the diagnosis. So this is a quick summary. By referring to above 5 surgical approaches, 95% of the brain tumor can be managed surgically. And again, I emphasize that we need a tailor-made patient-specific strategy for each patient. There's no individual brain tumor that is identical. So every patient deserves a tailor-made surgical strategy. And we promote evidence-based treatment and study and state-of-art diagnosis, surgery, and chemo-radio adjuvant therapies. In our hospital, we emphasize we have the fortune to have heavy ion and baron neuron capture therapy. And as I mentioned, the latest technology of intraoperative MRI and the neural navigation, that's the current state-of-art neurosurgical approach for brain tumor in our institute. Thank you very much.